Among her many accomplishments, Dr. Lombe has been an ongoing consultant for the United Nations and has conducted evaluations for NGOs, including Catholic Relief Services, Entre Culturas, Oxfam America, Oxfam Great Britain, Global Ignition Advocacy Networks, and the Association of Members Episcopal Conference of Eastern Africa. Please welcome Dr. Lombe.
Thank you, Rose, for the kind introduction. All right, thank you. I am honored to have this opportunity to share my reflections on this important topic. I'm still waiting to see the slide. So I'd like to limit my thoughts this afternoon, evening, to the question of HIV AIDS. And I do this for a number of reasons. One being that the consequences of the pandemic continue to be severe despite effort made to eradicate HIV AIDS. And here I'm thinking of countries where the mechanisms for care, the mechanisms for treatment continue to be challenging despite the progress that has been made globally. Another reason relates to the alarming rates of children who have been orphaned by AIDS. And I'm thinking here of sub-Saharan Africa, where about 90% of these children reside. The other reason relates to commitment to stay engaged when the subject is no longer exciting, when it's no longer attractive. And there is the question of moral authority. I believe I have moral authority on this subject, specifically as it relates to sub-Saharan Africa. And indeed, social work does give me a platform for engagement. I'd like to draw your attention to the HIV AIDS timeline. You see that this spans from the 1980s to the 2020s and counting. So if we take a look, we'll see that currently there are about 38 million people living with HIV globally. And if we take another closer look, we'll see that sub-Saharan Africa reports higher rates of HIV compared to other regions. And this stands at about 25 million people. Another closer look at this picture suggests to us that women are disproportionately impacted by HIV and AIDS. And in fact, what the data suggests is that about 4 in 5 new infections in sub-Saharan Africa are among young women aged 10 to 19. So why this picture, you may be wondering, as I've wondered for many years. And I'd like to offer a few suggestions to help explain this picture that we've just reviewed together. One is the lack of political will, and here I'm thinking specifically about world leaders and other stakeholders. There's also the fact that the question of HIV/AIDS takes on a moral angle, and there is abdication of responsibility. Indeed, the pandemic is seen as Africa's problem, and hence the responsibility for AIDS care and related initiatives have been relegated to the arena of charity, and it has been placed mainly on the shoulders of non-governmental organizations, both local and international. Just last month, we celebrated the malaria vaccine. We have reason to be hopeful, despite the fact that in 40 years, an HIV vaccine continues to be elusive. With regards to PrEP, what we see is that PrEP is not readily available in poor countries, despite the fact that these are the locations that are likely to report higher rates of HIV. So as we grappled with the picture that we've reviewed together, my students and I took the question of getting to zero, which is actually a United Nations UN AIDS framing. So we took this question to a rural community in sub-Saharan Africa, a place called Chikuni Mission, to be specific. And we broke our question up, and this is the question of getting to zero. We broke it up into 5 key areas. How does the community understand the concept of getting to zero? Do communities even care about getting to zero? Do they have the resources to get to zero? What are their aspirations to getting to zero? And who are the key actors in effort to get to zero? And why these actors? So we collected our data through semi-structured interviews with selected groups from the community, and our sample size was 52. The groups that we interviewed included youth, district officials, healthcare practitioners, religious leaders, and community members who consisted of grandparents, parents, and educators. We also interviewed personnel from the local radio station. And our interviews focused mainly on the 5 key areas that I alluded to. And these interviews were recorded using a handheld recording device, and they were translated from the local language Chitonga into English where necessary. And we interviewed in locations that allowed for discussion, as well as respected the privacy of the people that we interviewed. And we transcribed our interviews and analyzed the data using NVivo 11 for Windows Pro. So this is just an example of one of the locations where we conducted our interviews. Another example, and as you can see, we also conducted our interviews under shady trees. And thanks to the generosity of the Sisters of Charity, we used the convent to conduct some of our interviews. So what did we learn from these interviews? Our sample was mainly female at 54%. And looking at the question on the concept of getting to zero, what we learned was that the community's understanding of this concept mirrored UNAIDS conceptualization and focused mainly on zero discrimination, zero new infections, zero new deaths, and zero gaps in care. With regards to the question on aspiration to getting to zero, we noted a number of perspectives, and these ranged from pessimistic to more optimistic perspectives. We heard things like, it's too ambitious, it's not possible, it's unattainable, to things like, it is a positive aspiration for the community. It needs a lot of time. It is something that requires involvement of everybody, the government and the community. Looking at the question that we asked on resources needed to get to zero, 2 critical resources emerged from our interviews, and these were social support and home-based care services. We also noted a number of challenges, including poverty or lack of resources, stigma, which the community looked at as the #1 killer. And we also saw lack of accurate information and tradition as challenges to getting to zero. And on tradition, gender norms and cultural practices were identified as major challenges. With regards to gender norms, the community underscored gendered scripts that facilitated the subordination of women as problematic. And on cultural practices, they highlighted ritual cleansing as problematic in efforts to get to zero. And we also learned of strategies that could be effective to getting to zero. And here I will highlight only two. One being enhanced nutrition, which the community connected to retention in care and treatment adherence. The community also saw the need for engagement among traditional healers, religious institutions, and healthcare providers as important to getting to zero. With respect to our question on the critical actors to getting to zero, if we're to summarize all the responses that emerged, our summary would read something like, it starts with me. And indeed, from the youngest to the oldest person that we spoke to, they all felt they were the critical and primary actor in effort to get to zero. So what does this all mean? And I'd like to locate my implications into the broader framing of the topic that guide our discussion this evening. And I organize the implications into three broad categories, including engagement, global health financing, and innovative responses. With regards to engagement, I encourage us to rethink models of responding to global pandemics, in that the models that are currently in place may not be adequate in capturing the complexity of pandemics. And I offer here the framework of layered vulnerability as a model that might be important in helping us understand the issue, as well as identify critical intervention points. Another factor under engagement that I'd like to highlight is investing in understanding the local reality. And indeed, I'd like to argue, communities like Chikuni Mission may be overwhelmed by the experiences of HIV and AIDS, but these communities are also the locus of strength. They are the locus of resilience. These communities also have aspirations for themselves and their children. And most importantly, they live with the consequences of our good intentions. Another element that I would like to highlight is the need for multisectoral approaches. And I'd like to suggest here that if there have been any lessons that have been reinforced by the COVID-19 pandemic, it's that pandemics are not only experienced as health problems, they are a grave economic and security threat, and hence the need to address them through multisectoral approaches. I also call attention to the need to rethink collaborations without team science. But the question is, who's at the table? And here I'm just drawing attention to the need to bring community voices into interventions that we create. With regards to global health financing, I draw attention to the need to rethink how global health is financed. Indeed, we know that preparedness is critical for quicker responses, including prevention, and hence the need for financing mechanisms that can be mobilized quickly to bolster global health, security, and pandemic preparedness. And finally, I draw attention to innovative responses. And the current thinking leans towards mobile health. In the case of sub-Saharan Africa, we know that cell phones are widely available and accessible. This calls for creativity in the use of this mechanism to deploy critical life-sustaining knowledge. And this has potential to reduce stigma. And in the interest of time, I'd like to stop here. I thank you for allowing me the space to reflect with me on this critical topic. And I leave you with our publication from the Getting to Zero study. Thank you.
Thank you, Margaret, for that thoughtful presentation and ideas for innovation. Now we're going to have our next speaker, who is Dr. Nandakumar, also known as Dr. Nanda. He's a professor and director of the Institute of Global Health and Development and academic director for the Global Studies program at the Heller School of Social Policy and Management at Brandeis University. Professor Nanda is also a BU alum and member of the Center for Innovation in Social Work and Health Advisory Board. He is an internationally recognized health financing expert, known specifically for his work in resource tracking, health financing, and healthcare policy and research. A former Indian Administrative Services officer, Dr. Nanda has also served as the first chief economist for the Global Health Bureau at USAID, where he provided intellectual leadership relating to all aspects of health economics within USAID Bureau Global for Health, and provided expert strategic and analytic support to USAID global health work in priority countries. As a senior program officer at the Bill and Melinda Gates Foundation, he assisted with the development of the Global Health Delivery Area strategy and the India strategy. He has worked and conducted research in countries including Bangladesh, Egypt, India, Jordan, Kenya, Lebanon, Myanmar, Mongolia, Rwanda, Tanzania, Tonga, Western Samoa, Sudan, Yemen, Zambia, and here in the United States. Please welcome Dr. Nandakumar.
Luz, thank you. Thank you for those very kind words. I have a very strong link to BU. I'm a BU alum, but my wife, has a very strong connection to the School of Social Work that she always remembers very fondly, though she has now kind of defected to the School of Law. But so thank you for giving me this opportunity. I am an economist by training, and so I'm going to give you the economist perspective of a very interesting and very unique experiment that is ongoing. And this is the first blended finance facility for pandemic response that has been established in the world. And the hypothesis we set out to demonstrate by doing this was that you can actually leverage markets and innovation to reach the most in-need populations. So this was something that is quite unique, both in its construct, but what I think we set out to achieve. And one of the roles I have is as a senior advisor to USAID in India, and I've helped them set this up. Now, just as to set the stage, what we should realize is that India had a serious number of cases of COVID-19, and after the United States has had the largest number of deaths. Now, one of the things to keep in mind is that the world was awash in debt even before COVID hit us. So we have to put everything in a macroeconomic context, right? And an interesting feature of this debt was that private debt was growing exponentially, right? And also what you see from this slide is that debt was increasing at a rate much faster than the rate of economic growth. So even before COVID came and disrupted the global economy, we were at the precipice of incredible amounts of debt, right? And what was being privately held. Now, during the pandemic, we have added 24, now probably $26 trillion in debt to combat COVID-19, right? And what this has meant that the global debt to GDP ratio today stands at 355%, all right? Now, debt to GDP ratios in OECD countries, that are the high income countries that normally support global health, is over 100% in almost every single country. So, and the situation, if you look at low income countries, in terms of their debt to GDP ratios, is even worse. So what one is starting to see is a significant constriction of the global fiscal space. And what that means is the ability and willingness of countries to kind of lend more or give more as grants to other countries is going to become less. And the ability of government to spend on health and other social services is going to get severely constrained. So when we saw this situation, what we decided to do, and looking at the situation in India, was go a completely different route. And I've always written that pandemics kill in three ways. The first is the virus itself. The second, which we don't talk much about, is the disruptions to the routine healthcare system. And something we talk even less about is the economic stress that and the impact it has on gender-based violence, on the ability of households' mental health that pandemics lead to. Now in India, the first wave of COVID-19 basically impacted the marginalized populations, right? The migrant labor, the poor. And so the policy response to that was not as vigorous. What the second wave did in India was it breached the walls of the middle class and the rich. And once that happened, you saw the country waking up and wanting to tackle this on an emergency footing and at scale. I always joke when I was talking to my class, they said, what is the fundamental difference between what happened in the US and what happened in India? I always say that in the US, we probably listened more than we should have to the public health people and less to the economists and the business community. And in India, they probably listened a lot more to the economists and the business community and a lot less than they should have to the public health community. The impact on girls in India. The pandemic, we probably wiped out in India all the gains that we had made in about 40 years in girls' education, okay? 10 million girls probably dropped out of school. In the first 6 months, 12 million women lost their jobs. So there's a huge gender component to this. And we all know that when girls drop out of schools, you lead to all kinds of other problems: early marriage, domestic violence, right? They don't go back to learning. They're no longer, they're out of the labor force. And then we also realized that while the cities were doing quite well, we had these populations in tier 2 and tier 3 cities. And those who kind of were living in rural areas and the more marginalized populations that needed the most help. So we decided, could we have a solution that specifically targeted these population groups by leveraging the power of the market? And this is the social vulnerability index, and you will see that the social vulnerability index is pretty poor in many countries. So we took a completely different approach to dealing with this. And that was to set up a blended finance facility, and I'll tell you what it means. What were the problems we're trying to solve? What we realized was that we needed very high impact and relevant solutions, and we needed this done at super speed, right? We also wanted to have systems resilience that was built to prepare for future pandemics. And we realized that while the private sector may be interested, there was always this risk-return trade-off. There was limited access to capital. There was lack of incentives to adopt new innovative practices. There was a lack of market intelligence, and nobody was really organizing the market to function, right? And to expect big policy changes to happen, that was going to take way too much time. And we really did not have that time. So we set out with this goal of saying, can we identify 35 to 40 healthcare innovators, right? Can we mobilize, if we brought in $25 to $50 million in grant funding, can we mobilize $100 to $200 million from the markets, right? And then could that investment give us a 5 to 10x return? And keeping in mind that what we wanted was to get these services to the populations in need quickly. This is a very complicated graph, but what does blended finance mean? Blended finance means you bring in different instruments. You bring in grant funding, you bring in pure commercial capital, you bring in impact investors, and you bring in a whole range of financing tools that is available that you can deploy. These are things like credit guarantees, correct? First loss write-offs. There are various instruments that we have in our arsenal that we don't, and when you would like this, but there are lots of things that one can bring to bear in terms of what financing instruments are available that we don't use in the cause of public health, right? So we had this partnership with the government of India. We brought in a few foundations. The US government was organizing this effort and came to the table with both expertise and money. And I won't go through all the blended finance instruments, but as you can see, we have a range of things to do. What did we start as a basic principle? One, we had made in India solutions. We wanted solutions that were tailored to low resource settings. We wanted to make affordable financing available. We wanted impact at scale. We wanted vulnerable populations to be the focus, and we wanted what we did to complement and support the efforts of the government of India, right? And we wanted long-standing systems changes to take place. I'm going to spend the next few minutes talking to you about some of the investments we have made, right? So one was really some technologies that were addressing the last mile problem. What we found was that there were a lot of innovators in India who had the technology, but had never really worked in tier 2, tier 3 cities and worked in rural areas. What we wanted to give them was the runway, the money, and the confidence that we were behind them and we were willing to underwrite the risk, which allowed them to go and work side by side with the government for achieving a social good. And this is possible, right? And you will notice that the amount of money we are spending is really very small, right? In a typical world, we'd have gone and spent hundreds of millions of dollars in grants, but what one can see is if you're smart in how you do it, for very small money, you can actually achieve tremendous social impact, right? And we also had, for example, and what is interesting here is that none of these people that we have been funding actually come from the health sector. There are people who are from the non-health sector who are trying to solve big intractable problems in health. They're engineers. As a matter of fact, the person who decided that they wanted to have standalone clinics in rural areas, where people didn't have access for 3 to 5 miles, is a Harvard Business School graduate who headed up Bain Health in India and said, I really want to solve this primary healthcare problem in India. So what you're seeing is that these innovations are coming from outside, but you want to open the door to them. So we had, for example, technology, which was about temperature-controlled boxes. We had a supply chain network where we could use very innovative technology to get things to the last mile, right? We had PSA oxygen generation plants, right? And then we decided that there is a huge need for capacity building. So we collaborated with GE on training people, nurses, physicians, frontline workers, on how do you deal with pandemics in a responsive way. And what we realized is that there's a huge market for capacity building in India. So instead of us giving grants, this is how the US government works, right? So if you have $5 million, you give it to an implementing partner, they go hire people and they do capacity building. And then if you can double the money, they double the number of people. And then a year from now, they've done the work, they build you and they leave. There's nothing to show behind. One of the things that is coming out of this is what we are planning to do is to foster this market, which I believe is $20 to $25 million a year, which can be privately financed, privately resourced, and privately managed for capacity building for frontline workers in healthcare in India, okay? And so what we have been able to do through these solutions is take a different lens and approach to not just pandemic response, but how do you get services and innovations to those most in need? This is what we've been able to do. Look at the map. And this is work that has been going on for 6 months. We have been able to reach, at this point, nearly 3 million people. And the goal is to reach 30 million people, but spread it across the country, especially in the hinterland and more difficult to reach populations. We have also found that there are a number of nonprofit organizations where you can link them with micro enterprise. They work very effectively with women who are change agents, not simply to educate them on why you should get vaccinated and deal with vaccine hesitancy, but give them a means of livelihood, which is truly transformative, right? And what we are now, within 6 months, given what the government has been doing, one of the lessons we have learned is that we need to pivot. We need the flexibility to look at new range of solutions that will address emerging problems. So all in all, what I wanted to share with you today was that we took certain hypotheses that people had believed was not feasible, and we are demonstrating that it can be done. But what you need for this is good governance, due diligence, transparency, and partnerships. Thank you.
Thank you to both of the presenters for these important points of view and perspective. And now we are going to have a discussion. And those of you who are on Zoom, if you can write your questions on the Q&A, that would be great. And you both present an innovative perspective, and I would like to start with a question for both of you. Dr. Nanda, markets are typically thought to only work for the wealthy and not for the poor. Yet your lecture talked about actually leveraging the markets in India to work for the populations most in need. This is turning a theory on its head a little bit, isn't it? Dr. Lombe, you also show us an example of a non-traditional model for HIV AIDS care, integrating the local reality. Could you both comment on these approaches?
You want to go first? Or you
can go first.
Okay, Luz, that's a great question. So what we are starting to see is that there are a number of entrepreneurs and investors who are committed to social impact. What you really need to do is, no investor is going to go in and say that they don't want to make money, they want to lose money, right? That is not how markets function. But the real question is, what is a reasonable expectation of return, right? And how do you convince the commercial investors that they need to take a longer time horizon and a more reasonable return on their investments? And that is where I think, if you can come in and underwrite some of the risk, and I'll give you a concrete example. We wanted to scale, primary healthcare centers, and we wanted them to go from 5 to 50. It would have taken $10 million as a loan, as a grant, but we could get them $10 million by underwriting 50% of the risk for $30,000. So what you need is, if you facilitate these markets to function, and you're very clear on what you want to achieve, you can help markets to respond to social needs.
Thank
you. I'm not offering a model of care as such, but I'll take a step back and say I'm trying to offer a model of understanding pandemics. And the context that I'm looking at is Sub-Saharan Africa specifically. So here we see that the socio-political context, and I use the model of layered vulnerability, becomes very critical, because the socio-political context is going to determine a lot of things, including access to healthcare. And so I'm looking at Africa, and Africa is seen as a land or location with high burden of disease, low healthcare expenditure, poverty, et cetera, et cetera. And so these vulnerabilities are also visible within countries. And within countries, there is a big rural-urban divide such that resources are available in the urban areas, and these same resources are not available in the rural areas. And within the rural areas, we see divides again within communities. People have access to resources, people who don't. And at a household level, there is also gender, which is kind of a primary divider. And so we see these layers and layers of vulnerabilities being reinforced. Even in the case of pandemics, it's these vulnerabilities that are reinforced to determine the experiences of pandemics. And my argument is that we cannot understand pandemics in Africa without looking at the layers and layers and layers that are going to define who's vulnerable and who's not. Thank you.
So now Ellie has a question from over here. Yes, I'm sorry.
Oh, you have to hold it. Thank you. All right, no. It's full service. Anyway, so Nanda, really fantastic talk. What I wanted to get your thoughts on, we've seen in the pandemic, the trust in the public sector has plummeted in this country, in India, in Pakistan, elsewhere. Are these kinds of initiatives where the government of India or the public sector is involved, rebuilding some of that trust, or is that erosion so deep that it will take a long time before, especially your socioeconomically vulnerable groups that have felt that there's nobody for them, and that there's some merit to that argument that they have been left behind in every country, in this and elsewhere as well. Are some of these efforts building that trust or rebuilding that trust?
I think that's a great question. And I honestly believe that these initiatives where you actually see services reaching quickly to these population groups, right? Restore some confidence in the ability of society to deal with these problems, right? So we definitely needed the government to be a partner on this, but what we wanted to do was to drive the solutions in a way that they were quick. So you need the government to be there, but you don't want the government to drive all the decisions, right? And eventually, people believe you only if they see tangible, concrete results on the ground, correct? And if they don't, then it's just a lot of talk, but not much action. So what I liked about the situation in India was the National Health Authority said, and the government said, we will partner with you, but we give you the space to make your decisions. We're not going to tell you where you want to put the money. So I think it goes a long way in restoring the trust, much more at the local community level, by saying that, at the community level, we are able to solve these problems. Because the government is so far removed quite often from the day-to-day lives that if they can see these changes, it becomes tangible and real. Completely agree with you.
Now we have a virtual question.
One question from the Zoom audience is, what specific role or roles can healthcare social workers play in achieving global health equity?
Oh, that's a big question. I'll begin by saying, don't shy away. We know the communities, and I'm speaking as a social worker. We know the communities. We are close to the communities. We know the people. And so one of the roles that we can play is to be attentive, like understand this community, be attentive. What is going on in the community is where we can begin from. And we are trusted by the community. So we are a natural partner to these communities. And so like we have leverage as we enter these communities because we are natural partners. So we begin from the partnership. And then, I'm not going to argue that the only people at the table should be social workers, but I feel we can lead efforts where we bring non-social workers to the table, like healthcare practitioners, for example, but we are leading the effort because we are in the community and we're trusted by the communities.
Thank you. Another question from our Zoom audience is, reflecting on the growing community, the LGBTQIA+ community in India, would either Dr. Nanda or Dr. Lambe have any experience working either with gender fluid, LGBTQIA+, or non-binary communities? And could you share some of those experiences? Thank you.
Yeah, I can take a crack at this.
Please,
So
please.
I was for nearly 4 years the chief economist at the Office of the Global AIDS Coordinator, and I continue to have a position at the Office of the Global AIDS Coordinator. One of the things that we have been dealing with is what we call the key population issue, right? And the typical way of approaching the key problem was that we had NGOs that were 100% donor funded, which would provide services to these key populations who were HIV positive or at risk. And there was no sustainability plan or empowerment plan. It was donors coming in, creating a parallel set network of providers that would treat these key populations. One of the things that we are experimenting with in India and in Southeast Asia is what one realizes is that these key populations have tremendous business acumen. They are extremely well educated, but they don't have the wherewithal to have support to create business enterprises that not only provide the services, but are self-sustaining for themselves and the broader community. Okay, so one of the things that we are experimenting with under what is called the Sustainable Financing Initiative is to see whether we can move these key populations from a donor-dependent model to something that is much more self-sustaining. And I honestly believe that we have been too fixated on the supply side interventions. It's all top-down command control. What we're not really doing is demand side empowerment, right? Which allows people to make their own decisions and be empowered to make those decisions.
My quick addition would be, working in sub-Saharan Africa, it's very challenging to work with people who identify as gay, lesbian, binary, because most countries in sub-Saharan Africa have policies against gays, lesbian, transgender, and so these people are not going to come out and claim their identity, sadly. But I sit on the Ryan White Planning Council in Boston. And at the Ryan White Planning Council, the role that we play is really make sure the resources are allocated equitably. And I'm not sure this is satisfactory because there's a lot of work to be done, especially with regards to HIV, AIDS, and the population that you have just alluded to.
Thank you. Another question from our Zoom audience is, what roles can education play in achieving global health equity?
It is at the core of this. There is a whole body of research that the institute that I head up is doing on what puts women, young girls, most at risk for contracting HIV/AIDS in Africa. And there's a whole other body of research we are doing on what are the positive spillover effects of these investments when it comes to macroeconomic growth and all-cause mortality. What we are finding is that agency, right, is extremely important and critical to understanding both the risk of contracting HIV, but also the ability to deal with situations. And young girls are most vulnerable in a power dynamic, and education, but not just education, but linking them up to jobs and making them part of the labor market, right, is what empowers them and is a very strong way of dealing with this.
Yes. My only addition is that really just underscoring what Professor Nanda has said. Education is a starting point. It gives younger people, like I've worked with younger people in villages, future orientation. Where does that future orientation come from? Where's my dream for tomorrow going to come from? Without education, there's no future orientation. I'm not futuring. My life is here now. And so this is like almost a fatalistic attitude. And so education is the lens through people will see tomorrow.
Thank you.
I think it's also, education is key to make transformation. And in the question that we had before, I think education can help to change homophobic ideas and to make more visible the stigma that is experienced by so many people in these communities. We also talked you both presented on a community participatory approach to research and practice. And you showed examples that only involving community members, hearing their voices, as well as including them in the decision-making, we can be effective. I can say that you both demonstrated how a community participatory approach is possible in Zambia and in India. So can you expand a little more? We continue in this trend and have community members in the decision-making process.
Thank you. You know, like my approach is kind of funny because I see myself as taking off my shoes. Like I take off my shoes, maybe physically, mentally, and I say, I'm standing on holy ground. Teach me what your life is. And one of the things I've learned through trial and error is that it's going to take time to learn how to live on less than $1 per day. And I'm not going to claim expertise in the way the community lives, its reality. I'm going to ask the community to educate me. And the community is very good at educating, but they're also looking for sincerity and integrity. If they see lack of sincerity, they know you're not there for the long haul, and you miss an opportunity to engage.
I think one of the big lessons that came out of the work we've been doing in India is that you have to tailor solutions that meet the needs of the community. And if you don't engage the community in understanding exactly what they want, you will have solutions that completely disconnect with what the community needs are. They are the ones that, it's quite interesting. I think we underestimate the knowledge, the power, and the resilience of communities. And the more we recognize that, and we are humbled by that, right? The more positive and impactful development investments will be.
I think that is so important, and that is a reciprocal process between the community and not us imposing Western models, but having a reciprocal process with participation of the community. I believe that now we want to thank everybody in the audience and virtually and here, and we're going to have Jorge say the final remarks.
Thank you. What a set of inspiring presentations. I learned so very much. Thank you for your amazing insights and research. Before closing, I wanted to say a few things that I mentioned at the beginning, that due to some audio issues, some of the audience and Zoom didn't have a chance to hear. Just quickly, I want to mention that this event is sponsored by the Center for Innovation, Social Work and Health of the School of Social Work at Boston University, and that the center's goal is to provoke thought and stimulate action consistent with the center's mission, which includes improving health outcomes, population health, promote health equity and social justice, and expand the impact of social work in health. I also would like to, before closing, to thank again our panelists, our moderator, and take a moment to thank Michelle Walsh and the marketing and communication team for their leadership in organizing tonight's event. Forrest and her development and alumni relations team, and to the center's executive director, Ellie Zambrano, of the center that have been so supportive and with whom we owe the gratitude of doing amazing work to that aligns with the mission. Thank you very much. We hope the information from this panel can help all of us take additional action in our work to advance health equity. Thank you and have a good night.